So my name's Cathy Bakaya. I'm a GP at St Andrew's Health Centre and at Bromley by Bow Health, and this is my first year being part of the NIS discussions. So I want to start off just by giving a little bit of context around what's happened with the NIS this year, and then we've got an action-packed, information-filled afternoon for you all about the NIS this afternoon to kickstart the year before we start in April. So as we know, the purpose of the NIS is to provide funding in primary care to tackle the work that reflects sort of the clinical and systems priorities for the year for the borough. And about £7 million is ring-fenced by the CCG for this purpose. And this slide just shows how the money is split into different areas. So we've had a lot of feedback from last year's NIS around how it's worked, and we've taken on this feedback and really changed some of how the process around developing the NIS has worked this year. And this slide just shows the kind of different stages the NIS development process has gone through in order to be able to kickstart for April. We've had a number of meetings where we've discussed the NIS with members of the LMC, and as Jackie said, they've been part of the discussions, and although she said no one from the LMC is here, I think I saw Archana walking in representing the LMC. And within the discussions, we've had Jackie, Archana, Emma Radcliffe, and practice manager input from Beverly from Wapping Health as well. For the first time, we've had the care group team as part of the discussions in the NIS as well. So this has included Chris Banks, Ruth Waters, Isabel Hodgkinson wearing her different hats, Yash and Aisha from the practice managers team as well, and Simon Harris representing the practice-based pharmacists. From the CCG team, we've had a number of people involved, including the contracts team this year, as well as Jenny Cook and Joe Sheldon. So we've had a really, really great combination of people scrutinising all aspects of the NIS to make sure that it's clear and fit for purpose for this year. So I want to say a massive thank you to everyone who's been involved in the development process of the NIS, and also to the practices and individuals who fed back on the NIS in order for us to be able to take on this feedback and improve the NIS for the coming year. And as Jackie said, I'd like to reinforce that it'd be really great to just have that two-way dialogue continue in year as well, so we can continue evolving the process going forwards. So this is what the agenda looks like for the afternoon. I'm hoping that as everyone came in, that they have signed up for the workshops this afternoon. So we have 3 different workshops for everyone to attend, but there are actually 5 different themes that are being covered in each of these workshops. And the idea is that within your network team, everyone goes to a spread of these so that there is information collected that covers all the different themes for each network. And I'm hoping that the network manager is going to help sort of divide and coordinate the teams around this. The workshops are there as an opportunity to get a little bit more information around each of the different aspects, the changes specifically that have occurred, and also as a way of being able to ask questions in smaller groups as well. So you'll have seen that there are different themes, including prescribing, enablers around diagnostics, anticoagulation, dermatology, and a few others. So for the next 20 minutes or so, Jenny and I are just going to go through some of the big changes in the clinical KPIs of the NIS and the enablers as well, and talk through some of the changes that have occurred as a direct feedback from yourselves, from the practices. Is everyone okay in terms of seeing and hearing? Just wave at the back if you can hear. Just to say that you'll notice there aren't any handouts, because all these slides are going to be available on the Tower Hamlets CCG website, the CEPN website, and every possible website that we can think of. So the communication from today will be available for those that are not here as well. So if the network teams can please feed that back and sort of communicate that to the teams who haven't been able to make it, that would be absolutely brilliant. Okay, so the NIS specification has a new look for this year, and you'll hopefully see that the NIS specification this year is a lot briefer as a starting point, and hopefully much clearer as well. We've set this out into 4 distinct areas, including clinical KPIs, prescribing, enablers, and new investment. And you'll know from this year that the clinical KPIs come into 2 separate categories. There's a payment category and there's a monitoring category. And for the coming year, we've made it really clear what targets are payment related and what are for monitoring purposes only. And the purpose of the monitoring KPIs is really to still keep our focus on certain areas and possibly to help inform us for the priorities for the future. One of the pieces of feedback from last year was confusion around who the go-to people are for the NIS, and the care group have been really proactive this year in making sure that there is clarity in who to ask when questions arise in year with regards to the NIS. So at the moment, there is a NIS contact sheet that's being prepared by the care group to share with the networks around who to contact if any queries arise. In the meantime, the overarching go-to people are Ruth and Yash. Are they here in the room? Brilliant. If you could just wave at everybody. So for those of you who don't know Ruth and Yash, there's some faces over there. Jackie mentioned in her video about the rolling 12-month contract. So she's quite rightly said that this has not been implemented for the coming year, and actually that's directly as a result of concerns raised by practices around the impact on workload. And so if this is something that we want to explore for the future, there will be a working group that will need to be developed, that will need to develop the idea, potentially test it in shadow form or in a small patch, but there are no firm plans around taking this forward yet, and we'll keep you posted as things develop. So care planning's been a real mixed bucket, actually, and this is a really resource-intensive piece of work. But I think majority of us agree that when care planning is done well, it has huge benefits to patients. But there has been lack of consistency about what good looks like, and more training has been requested. So we're beginning to sort of address this today by featuring this piece of work in one of the workshops today, and you'll see that CEPN will have some training around this coming through to address this. You will remember from the planned care audits and various other aspects of the NIS that there are in-year audits that are requested at quite short notice in the past, and there's always been placeholders for this, but it's been difficult for practices to respond previously within the sort of 6 to 8 weeks period that has been requested in the past. So going forwards, we've agreed to extend this to give practices a 3-month notice to complete these audits. Jackie also mentioned in her video that there was confusion around BP targets in the ICCQ NIS. Previously, there was only one BP target for patients with hypertension, diabetes, and CKD, and this has actually now been disaggregated to make it a little bit clearer and based again on the NICE guidelines. So this slide just shows how they've been disaggregated, where different targets have been set for different areas. So you'll see that for diabetes blood pressure targets, there is a target of 65%, whereas for CKD it's 40%, and for CVD, patients with hypertension, is set at 80%. This is really to recognise that it is difficult to meet these targets in different groups, and obviously the tighter the target, the more tricky it is to meet this. So this has been reflected in the different targets set against each of these benchmarks. So I've just mentioned before around the clarity and the difference between a payment metric and a monitoring metric. So this slide demonstrates that the blood pressure targets are a payment metric, but down here there is an ask for collecting a urinary ACR, and this is a monitoring metric for this year. So on to the referral management work. The focus for this year is to make sure that practices are getting accurate baseline data to be able to do these audits, and a much clearer definition of what the ask is. So one of the workshops today will cover this, and referral management is a bit of a misnomer, as Jackie said as well. This isn't really about managing referrals, but more about understanding why there is a big variation across the borough in how practices are referring to different specialties, and this is and understanding this variation really is a starting point to understanding whether there are learning needs or whether there are other issues as to why these variations are occurring. And then prescribing. There's been masses of feedback around the prescribing NIS, and this has been taken on. And you'll see, hopefully, from this year's prescribing NIS, it's been massively simplified. There are less elements to it overall, and it's all in one place rather than being in different parts of the NIS. There is a commitment from the prescribing team to offer visits early in the first quarter to initiate these meetings, and hopefully you'll have all seen emails asking for dates already from the prescribing team. The information and the templates are ready and will be available from the 1st of April to kickstart any work early in the financial year. And there's been an ask for a structured submission template for audits in the past, which we've sort of responded to for this year's NIS as well. There is a specific opiates audit which the workshop will talk about this afternoon, and you'll notice that there is a caveat in place as well for this audit. So there are targets set around which we need to improve prescribing this area by, but the prescribing team have agreed that if the targets are not met, providing that the work is done, we can demonstrate reasons why the target hasn't been met, there won't be any financial penalty, and we'll still be paid for the work, recognising that the work has been done. So just going into a bit more detail about the clinical KPIs from the ICCQ NIS. So I'm going to, for the next few slides, sort of highlight some of the changes that have been made, and I want to just give you some reasons behind why these changes are made. And part of the process of sort of setting the KPIs and the targets, we looked at the national guidelines, and if there were any changes in the national guidelines, these are reflected into our targets and our NIS as well. And you'll see this with the COPD KPI going forwards. And there are some areas where we haven't really changed the actual ask of the work, but the level, the target change, like the 65% bit or the 45% bit, this has been changed. And the way we've set the targets are by looking at how the borough how networks are performing, the averages, looking at individual practice data, and set a target that's been agreed by the colleagues that I've mentioned earlier as something that should be attainable by sort of practices or networks, rather than something that is not really realistic. So here's an example of a KPI that's been changed or added based on a national requirement. There's now a requirement to question about substance misuse as part of Part A of care planning. There's currently no code that allows us to put in that patient has declined to answer, but we're in the process of requesting this code to be added. And in the meantime, there is a free text tick box which we can use in the interim. So the COPD KPI has changed to incorporate recording of the COPD assessment test score this year, and this is based on the recommendations from the recent GOLD guidelines. The guidelines recommended COPD severity is graded not just by the FEV1 but a combination of the FEV1, the history of exacerbations in year, and also symptoms, which is picked up by the CAT test, the COPD assessment test. So because this is new and for various other reasons, this is a monitoring metric and not a payment metric. And again, this has been clarified within the spec of the NIS. As a group, when we were discussing this, we felt that, this is additional work, potentially, but that this work could be done outside of the consultation, either beforehand or using some of the technology, texting, and so on. So this is something around, there's something around how networks choose to do this, how practices choose to do this, which might vary, and there's something around sharing what practice works, which we can talk about in year as well. In the previous year, referral to pulmonary rehab for patients with COPD was a monitoring target and didn't have a payment attached to it. And we've swapped this around with another metric. So we have a significant number of people with COPD exacerbations in year, and so we've decided this year to focus clinical practice on pulmonary rehab. And so this has been changed from a monitoring metric to a payment metric. But the target, which was 80% previously, has been reduced to 65%. There were concerns about how our care are sort of set up to respond to this, and we've had some dialogue with our care to kind of reassure us around being able to meet some of these expectations, but also, this is another thing that we need to continue in-year conversation about as well. So this bar chart demonstrates how we've been looking at setting the targets. And I just want to not really go into too much detail about it, but this is around AF and the prescription of anticoagulation. So appropriate treatment with anticoagulation for patients with atrial fibrillation for stroke prevention is a really big priority in this area for this year. And so we've set the target at 90%, which sounds quite high. But there is strong clinical evidence and guidance around this area. And when we looked at existing data, many practices were meeting this already. So the target for this year was set at 90%. But when we looked at this second bar chart, at the end of quarter 3, 6 out of 8 practices were already achieving 86 to 90%, and the borough average at the end of quarter 3 was already 87%. So the previous year's target of 80% felt like it was a bit low, and so a 90% target was agreed based on something that was achievable, realistic, and sort of highlighting this area as a priority. Again, we did something similar with statins, but it's a slightly more contentious area, and we've recognised this, that offering patients statins for secondary prevention has always been a bit tricky in practice, and so the target has been moved to 64% based on the fact that the borough average was over 64% already by the end of quarter 3. So this felt like it was a fair target, again, which was achievable. And similarly, the cognitive assessment test was set at 60%, but the borough average by the end of quarter 3, when we looked at the data, was above this at 64%. So a new target has been set at 64% for this coming year, with the feeling that, again, it's achievable based on the data and information that we have. So this is something, gestational diabetes is a new piece of work this year, and the aim of it really is to improve our coding, monitoring and management of women with gestational diabetes with the aim of preventing diabetes in this already high-risk group. A lot of background background work has been done around this, and it reveals that the practices really vary in their coding and follow-up of this cohort, and without tighter management, many of these patients will go on to have diabetes. So in addition to what we see on our side in primary care, existing data shows that about 45% of women who have had diagnosis of gestational diabetes in pregnancy DNA don't attend their glucose tolerance test at 6 weeks in hospital, and this isn't massively surprising. So up to 45% of patients not turning up. It didn't feel like we were doing the right thing by patients, didn't feel like we were doing the right thing clinically. So the ask is, for this coming year, is to identify and code patients with gestational diabetes at their postnatal check, which hopefully many of us are doing already, but also to offer them an HbA1c test at 3 months postpartum, after they've had their baby. This is really something that hopefully will make the diagnosis a bit easier for the patients to be able to get to practice, and hopefully clinically we'll see an improvement in practice around gestational diabetes management and the ongoing diagnosis of sort of diabetes. The next few slides I'm not going to go into in detail or read them out, but what I want to show you, I just want to demonstrate, is what the spec will look like and the slides that you'll have access to. So these are summary slides, and what this lays out is clarity around, my mouse isn't working, clarity around at the top, what is payment and what is monitoring. The spec looks a lot more contract-like, so it's very clear what the ask is and what the target is. If there has been, the information you'll have will show that if there has been a change, what the rationale behind that change was. So whether it's, as I mentioned before, a national ask, or whether it's based on our performance in the current year. So similarly, at the top we highlight that this is a payment metric, and again, the disaggregation is shown here. Where there is new work, we've highlighted this as new work as well. And then there is, so we've just talked about this, we've talked about the COPD assessment test being added as a monitoring metric for this year, and just to highlight that what we've done is swapped it here for the COPD and looking at steroid prescription, which previously was a payment metric, has been swapped to a monitoring metric. So we've kind of swapped over the steroids and COPD for the pulmonary rehab. So these summary slides again will be available on the CEPN and the CCG website, along with a summary slide again of the changes related to prescribing. Okay, I'm going to hand over to Jenny to go through enablers for us.
Thank you. So my name's Jenny Cook, for those of you that don't know me. I'm the Deputy Director of Primary and Urgent Care at the CCG, and I'm just going to talk super briefly about some of the changes to the enablers section, which always sounds a little bit vague, and people always say, what do you mean by enablers? But it's kind of the bits of developmental work or the non-direct clinical KPIs that we use the NIS to facilitate each year. And broadly, much like the clinical KPIs, the changes haven't been hugely significant. They generally reflect the feedback that we've had, and there'll be some quite detailed discussion in one of the groups, one of the workshops, the second one, around the referral management aspects of the NIS, so we're not going to go into that too much right now. Do I just click along? There we go. So care planning quality, I think this is something we've grappled with quite a lot. So we used to have very clear targets around care planning, and actually the feedback was that that just reflects a tick box. You can say a care planning's been done, but actually what does it feel like for the person on the other end of that? And so we're going to be deploying this Collaborate tool, and again, just to make a plug for one of the workshops, the care planning workshop, we're going to discuss this in a bit more detail, but it's really to get a sense from the person that's on the other side of the care planning experience about what it was like. And this similar tool is going to be used across the alliance partners in the borough, so they'll get a real sense of how it feels for our patients. There's some changes around the cancer element. Again, a further plug, there's going to be the long-term conditions workshop is going to look at cancer, but really this is a really similar process, and it's really similar to the referrals idea, and it's really consistent with what we're trying to do broadly, which is about giving practices the tools to look at particular elements. So this will be looking at cancer diagnosis, to look at what happened to that patient, to reflect on it as a practice, and to, if necessary, implement any changes to your pathways within your practices, but then really importantly, evaluate and share that more broadly. So really similar theme, but just a slightly different focus around the cohort for next year. We've touched on GDM, but the other element of the GDM is around the retrospective coding. So again, I think practices will all attest to the fact that if GDM is picked up by the hospital, the coding's really inconsistent if you find out at all, if it comes back in the letter. So this is about retrospectively looking back to case find for people that we think might have been at risk of GDM and to get that consistent coding. And Jackie touched on the children's element of the NIS that hasn't been fully formed, but it will be very, very similar. So it'll be about giving practices and network searches that they can implement to ensure that we've got consistent coding of particular conditions. And we've also said in there that by in Q3, we'll start to, once we've got that picture of what that cohort of patients is, there'll be a group to look at what we then do with that. Because it's all very well coding and finding those patients, but then we need to have a clear kind of pathway in place for them at that point. And then these are the kind of the new kind of reinvestment areas that Jackie touched on, and I'm just going to go through them really briefly. Much of them will have been picked up already in the content. So we've put a 2% uplift on all of the long-term condition care package numbers. So basically the payment that you would get for diabetes, COPD, etc. Has been uplifted by 2%. For the complex care cohort, there is a review being undertaken at the moment that's looking at some of the increases that we've had in emergency admissions and mainly into Barts Health, but across the board, and looking at whether the people where we've seen these increases in admissions, are those patients covered by any care package in primary care? And we think there might be particular conditions that we've just not invested care packages in, be that complex, in the mandatory element of complex or in some of the other long-term conditions. So we've earmarked some funding to implement in Q2 that'll give practices the chance to expand the mandatory cohort based on the guidance that comes out of this analysis. So the analysis isn't complete yet. We've had some indications of some of the areas we might need to look at, but it's not complete. And actually, if the guidance tells us that there aren't huge numbers of people being missed, we'll allow practices, we'll distribute the 345 patients and allow practices to add that to their discretionary cohort. So either way, it'll be coming in Q2, and it may come with some very specific guidance, or it may come with some flexibility. The SMI cohort we've touched on, so there's a lot of patients who have antipsychotic drugs but aren't currently covered under the SMI cohort and aren't covered under any of the other long-term condition care packages. We've earmarked a small piece of project work that we expect to be delivered centrally, which is looking at some of the follow-up offers for those with SMI diagnosis. So there's a big push in the long-term plan, a big push nationally around physical health for people with severe mental illness, and there's an ask that you make all of these referrals into other services if you identify somebody that's at need. We're not desperate to implement that as a target or put it into one of the NISs at this stage, because actually we don't know if the interventions are out there, and it's pointless referring people into services that don't exist, or referring people who don't want to be referred, or where it's not suitable. So actually we just want to do a piece of mapping this year that looks at the guidance and looks at what's available in the borough, so that we can implement something sensibly next year and look at the mental health investment standard around this too. We've talked about the ADHD health check, so it's a really small number of patients, and this is to just do some physical health check work for that cohort, with all of the caveats that Jackie's described around working with ELFT on the pathway more broadly. The learning disability, again, this is something that everybody's already been doing. It was in the LIS, which, to add another acronym, was the incentive programme that sat across the providers, so it sat across ELFT, BARTs and the GPs, and this is just saying actually this was a really valuable piece of work. It looks like this year we are very close to hitting the 75% target, which is a really phenomenal increase in the last couple of years, and we really want to keep that going. We want to make it part of the NIS business as usual. There's been changes to the latent TB programme, but there's also a piece of work, again, we want to do around some audits of what happened to those that had TB screening. Again, a kind of small piece of work that may be managed centrally. And then finally, the bit that requires some further scoping, but we've earmarked a fairly sizable amount of this reinvestment fund to, is around both safeguarding approaches, recognising that it's significant amounts of work for practices to engage in safeguarding approaches, and really, really important that we get right and it's consistent. And secondly, around case finding and coding for a range of conditions for children and young people. So thinking about things like epilepsy, wheeze, asthma. Actually, it's really difficult for the commissioning team at the CCG to make really coherent cases around care packages of support for children and around looking at alternative services, because actually the data is really patchy, the coding's inconsistent, and that's because we've never had a strong focus on it. So actually we want to spend a year getting the coding right and up to date so that we can look at the pathways in the longer term. So that's that overview. Most of it, like I say, we've touched on, but we want to spell those out clearly.